brief introduction before handing over to Michael, who's going to present a case study on how we've contributed to improving patient flow at one of our customers in Norway. But we have an established reputation and growing client base in Scandinavia. The reason for that is we are a Norwegian software company. We're part of a very large organization, a global assurance business called DNV. We were acquired in the summer of last year, but we have a 30-year history in delivering software solutions to the healthcare marketplace, like I say, predominantly in Norway, but expanding on an international program as we speak. Our reputation has really grown around digitally enabling new hospitals. So some of these hospitals that you can see within the slides, and Olav's, Osvold, are often referenced in things like the new build programs as a blueprint of a digital hospital. We have had the fortune of working across the globe with a lot of these emerging hospitals, for example, the Royal Adelaide in Australia, and others around the globe as well. And we hope to bring that to the new hospital program in the UK. So essentially, as I say, we're a software business, and our solutions are actually built around a platform and a suite of digital tools and applications that span a variety of arenas and use cases. So they be from clinical logistics, where we're looking at patient pathways, alarm monitoring, through mobility, where we can actually aggregate messages and alarms, alerts, etc. on a mobile, integrating with the support services, so things like porters, the transportation, housekeeping, catering, etc., through to other solutions around patient logistics, so the self-check-in, the wayfinding, through to patient portals, so patients can actually interact with their own health record, and also the building systems associated with their occupancy or their room, to giving a management overview, so giving that situational awareness of what's actually happening within the fabric of that hospital. So without further ado, I'll now pass over to Michael to talk a little bit about one of those cases.
My name is Michael. I have just started to work at DNV Imatis, actually. Before that, I was working at Haraldsplass Hospital in West Norway as a nurse and also a project manager for implementing the solution from DNV Imatis at the whole hospital. So what I would like to do is just tell you how it went down and how it goes now in the hospital. About Haraldsplass Hospital. It's a diaconal hospital in Bergen in West Norway. We have about 170 beds, about 100,000 outpatient patients, and about 1,200 employees. But we also are a part of the Western Norway Regional Health Authority, which have about 1.1 million inhabitants and around 50 hospitals and institutions. So what Haraldsplass was, it was a pilot hospital for the Western Norway region. So everything we managed to do at Haraldsplass was implemented now in the rest of the region as we speak. Our former reality at our hospital, I think, looks kind of like this. We have a lot of ways to communicate with the patients. We have a lot of ways to communicate in-house. We have many things to have overview over. But in total, it was a big chaos like this. And also, if you look at our systems, we have a lot of silos. We have the surgery program. We have a program for porters, food service, for the EPR and stuff like that. And they did work kind of good enough, but they have one thing in common. They didn't speak to each other. So we used a lot of time to obtain information, try to coordinate the systems together, and So how was our dream scenario? It should be like this. We should have the information we need when we need it at your hand. It doesn't matter where you should be when you collect the data. I'm currently in Italy, and if I should be on a plane where the pilot didn't know where the landing stripe in Rome were before he left off, we would have a problem. And I think we have kind of this problem in the hospitals. We start a journey with the patient and we don't always know where it will end. How did we find out what we wanted to, how we wanted to set up our hospital? We did a lot of user stories. We asked the nurses, the doctors, but also the porters, the cleaners, the people who were making all the food, and the technical person. How is your day-to-day, and how is your dream scenario in the future? How would you really like to work in the future? We have a lot of interviews and we observed a lot. We sat beside the doctors and the nurses. We did a lot of documentation to see how can this dream scenario come true. We also looked at a lot of unsolved projects that has been done the latest 8 or 10 years. And we found that there were 104 identified issues that were unsolved in different projects. And I will come back to that later. This is not my words, but I think it's time to talk about it. The challenge no longer lies in the technical solutions, but how we people are using the systems and how we are not using it correctly. And with that in mind, I think this is one of the most important things for, I will take this down a bit, sorry. This is the most important thing of my presentation today. It is people we are working with, and we have to find the 2%. By that I mean, in every ward and in every hospital, you have some people who really would like to do changes using technology. Find these 2%, and you will easily get this to be 4%. And then you have the snowball rolling, and you will have 8, 10, 12%. And then you have the capability to do the huge changes in how you work in a hospital. So it's easy to implement the technology, but it's how you want to use them that is the huge work. And then you have to have some really good people working with you in the hospital. So what I would like to do now is just to go through what we have live in our hospital at Haraldsplass. This is only a small part, 50 minutes. It's not a long time, but we can have the overview. We have now the complete overview at all levels in the hospital. So we have the patient flow. Where is the patient? Who is responsible for the patient? What is the plan for the patient? Everything around the patient in the ward and also in the outpatient clinics. We have all the resource management. What's planned for the patient today? When is he going to X-ray? Is the porter ordered and stuff like that? We have a lot of alarms connected to DNV Imatis, for example, nurse calls, alarms from critical alarms, and also the possibility to make your own notification and alarms, automations of alarms. And of course, we have a lot of patient safety whiteboards available. And also we have this hospital process goals. For example, we would like to discharge the patient at latest at 1 o'clock. So that we have a better flow in the hospital. So this is helping to achieve that goal. We looked at this a couple of minutes ago, and we saw that when we have implemented DNV Imatis at our hospital, we solved half of the identified issues without any customizations. So we took the whole thing without tuning it in, and we solved half of the problems we have struggled with for many years. So that was an eye-opener for us, and we easily found that the 2% were increasing to 4%. You can see that this is actually working. So now we have a seamless connection of all platforms. We use huge touch screens in the wards. We have on the overview of patients and the plans on the computers. Doctors, nurses have information bedside when they're visiting the patient. They can inform about blood results and stuff like that without going back and forth 2 and 3 times to the ward to find the answer. Inside also we have a complete chat, call and communication platform that if you know the name of the patient, you will easily know who's responsible doctor, who's the responsible nurse. You can order porters and stuff like that within the same platform. And now to this to the headlights of my presentation, I think. When you really like to work differently and you're using technology to help you, you will manage to do a huge improvement in how you work. So this guy sitting here is Jesper Blomqvist. He's a head doctor for orthopedic in his outpatient clinic. He has a team of 3 physiotherapists, himself and 1 nurse and 1 other physiotherapist for pre-instruction before surgery in his team. But they have a huge problem. They had very long queues, more than 2,500 patients waiting. It will of course be great frustration, both in-house in the hospital and also out. The patient will be angry, they have to wait too long. And we have problems with the collaboration between the professional groups in the hospital. So how could we make this flow easier to get more patients through? Well, what we did, instead of making all the work go through the doctor, we set it up differently. So we have a digital flow that every patient were going through a physiotherapist at first, and then they are doing a mark in the whiteboard on the computer saying that, can you please look at this patient, Jesper? Jesper was using only his iPhone during the day. He was just going through from room to room, looking at the patients, and all the physiotherapists were doing the documentation. They were doing all the preparations, and the nurses also help with preparations if there was need of injections or something like that. So instead of the doctors only having one list with 16 patients a full day, he has now 4 full lists of 16 patients, and the doctor was just going in between. So we have the same kind of resources, but we know that we only had 1 orthopedic doctor, so we built the system around that doctor. It took us 2 hours observation on site, 2 hours talk with the doctor, 2 hours for me to set up the new flow as a nurse, and then the next day we went online with a new flow. So this is kind of the flexibility in the DNV Imatis system. You can do a lot of configuration yourself. The flow from the ER to the wards are fully digital at Haraldsplass. So the head nurse at the ER are just pushing 1 button at the whiteboard, and then the coordinator at the ward getting a note on his or her iPhone. We have a new patient for you. He will then put on who is the responsible nurse at the ward and send back the automated message. The patients can now come up to the ward. So then we get a better flow through the hospital. And now everybody will say that, well, we have to speak to the patient and we have to speak to the other doctors. Yes, we have to do that with 5 or 10% of the patients. The 90% others, you can do an automated flow, and it works perfectly. We have the digital whiteboards, as I told you, on all the wards, so we can have morning meetings, or we can have short meetings of 2 or 3 or 4 minutes. How is it going in my ward now? And we can use it also as an overview at the ward. The good thing is that when you're not present at the whiteboard, it will be anonymous. So you have to put your card on the side of the screen, and then everything will open and you can see the name and stuff like that. We have all these other systems, and you are planning in one system for X-rays, and one system for surgery, and one system for other things. By collecting all this data through DNV Imatis, everybody will have a list over what's the plan for the patients today. And this benefits both the wards and also all the connecting workers for physiotherapists, CT scans or stuff like that. They will know when should the patient come, when is the patient available. The physiotherapist doesn't need to come at 2 o'clock because they know that the patient is in another place. We have a fully automated housekeeping service flow. So before, we have to call the cleaners if they have to clean a room when the patients are leaving, or if there was some COVID on the room or something like that. Now, when they discharge the patient from the journal system, there goes a message through Imatis to the cleaner that this room is now ready for cleaning. It has been COVID on it, and we would like to clean it as fast as possible. So what you immediately achieve is that the flow from the ER is much better, because the cleaning facility person know which room to take first. So he's not going anywhere with some maps and go from one room to another. He now just goes straight to the room that we want him to clean. The same thing with the porters. Everything is pre-filled in the whiteboards, so they only have to push one button to select where should the patient go. And then we put on all the information about COVID, which room you are in, who's responsible nurse, and all this stuff. And when the patient are going back from, for example, an X-ray, they can turn the trip with one click on the whiteboard at the X-ray facilities. We also have anonymous reception reviews. The GDPR is strict in Norway also, so we cannot show too many patients at one time in the reception view. So now they only see the patient they are looking for, and nobody else. And by having these views, we saw during COVID that some patients needed to have visits and some couldn't have. And just to get this message from all the wards down to the main reception was a huge job. It took us 5 minutes, open one more column calling visits, and then we have zero work doing this communication. I have to speed up, sorry. We do all the food ordering from the patient through Imatis down to the main kitchen and the local kitchens. And we have this overall overview over the complete hospital. So this is the one the bosses are opening each morning before they come to work. So they will look at how many patients are there, how many will leave, do we have enough beds available today, or do we have a problem? Do we have to get some more doctors to work on discharge or stuff like that? In the end, we have self-check-in and payment facilities at the outpatient clinics. So you can check in on your mobile phone or on Automate, and you will be followed up by your iPhone through the whole stay. Both which room you should go to, payment, you can pay by invoice, or you can pay directly through the phone. Everything is automated. Thank you.